Okay, well, looks like it is right. Okay, well, looks like it is right at 10 o'clock Central. So we'll go and get started with our session 2 for the WPS Medicare Audit Provider Webinar. Now, this session, we're going to be covering the same things we did yesterday, but we're going to be talking about a variety of things. Some of these issues are carryovers from what we've covered in past webinars, but there are quite a few new things this session. So we're going to be covering all of those. And first, I want to just go through a couple of housekeeping items. One of the things to note here is that we'll be sending out an email with the recording link, the PowerPoints, again, if you haven't already received them, the attendance certificate, and the agenda, again, if you haven't already received it. So anybody that attended this session will be seeing that information here in a few days. I'll actually try to work on that tomorrow, but it might even go into the weekend or Monday before I get them all out, especially the attendance certificates. That sometimes takes a little bit longer. Now, the survey, there will be a survey at the end of the session. And actually, if you've already received the PowerPoint, you can certainly use that link. It's the same link, or you can use the QR code there, take a picture of that. We definitely appreciate if you're able to take a few minutes to do that survey, basically to give us feedback. And it helps us to improve the session, and it helps CMS to be aware of what we're offering, basically to providers and the community. Now, just as a reminder, though, that survey is just for basically non-MAC staff. So it's for providers, consultants, home offices, anybody that is not with a MAC, whether it be WPS or any other MAC. We cannot take those surveys there. So that's just one thing to note. And here again are the surveys. This is the 11th. So this is the one you want. And again, you could take, if you do the QR codes, you can take out your camera, take a quick picture of that, and it'll take you to the link itself, or you can click on the link as well from the PowerPoint that you have there. So as far as our agenda and our topics, so again, some of these are items we cover in many of the different sessions, but others are brand new, or at least new to the webinars. So we will still cover the S10 uncompensated care audits, just to give kind of a heads up, a refresher, maybe a status update is a better term for where we are with those and what's going to be changing next year as well. We will cover the DISH projects. Now, with this topic, it seems like we always have something new coming up. So some of this is going to be just refresher overview, but there are a few new things related to this. The third item, the extended low volume hospital add-on payment and the MDH status, basically just a status on what we know about this as far as where we are with the 12/31 expiration. We're going to cover a quick cost report refresher. And this is part cost report flow, but it really leads us into the discussion of what a provider needs to be aware of as far as making certain requests for cost center assignment. Grouping, we'll talk about the importance of consistency in grouping expenses and revenues, and then allocation, overhead allocation. Then we'll go through a refresher of nursing and allied health issues. We'll talk about a pretty new topic we really haven't covered in any training, any webinars. It's the all-inclusive rate providers. And the reason we're bringing this up is that there is something new that is going to impact psych providers specifically, but possibly other provider types down the road. We'll cover capital-related costs as a refresher, and that'll be the last major topic. And then we'll go through just a brief overview of the current website, webinars, and YouTube training resources we have available. Now, the questions, even though I have that at the very end, what I want to mention here is feel free to type in the chat area if you have any questions along the way while we're actually talking about a topic, because that way it's relevant right there. It's fresh in everybody's mind when we're talking about it. So I do have the chat area open up on another monitor, and I'll keep an eye on that from time to time. So feel free to do that. So with that, let's talk about S10. Oops. The S10 uncompensated care audits. So we are obviously currently working on those, and they are due by 12/31. So cost report periods beginning between 10/1/21 and 9/30/22. That's where we are with that. Now, we don't know for sure what CMS is going to do with this. For the past few years, they've used 3 years as an average. So the thought is that they're going to be using 1/3 of this data as part of the average for the next year's rates that'll take place 10/1/25. Of course, until the Federal Register comes out, the proposed and final rules, we won't know for sure. They can always change that at any point. Now, the one thing I want to mention here is that we're talking DISH eligible hospitals. Basically, any provider that has reported DISH on E-Part A line 34, that's who we're auditing right now. That's who we've been auditing for the past 5 years. This does include all SCH hospitals at this point, but in the next few slides, we're going to talk about some reasons why CMS may possibly change that. There's kind of some inconsistency in how they handle different things as far as the template requirement versus versus whether we have to audit it or not. The other piece about this is that it's, again, any hospital that has reported DISH on E-Part A line 34. So if you amend your cost report later on to add DISH, that's going to be included as well. Even if it's after 12/31, we'll have to report that. Now, the Federal Register, this is that SCH issue. If you look at the Federal Register, the 2021 IPPS final rule, there was a discussion where providers were, and others, were basically asking why SCHs had to be included in these audits, especially when their hospital-specific rate was already above the federal rate. Because really any additional UCP payment won't make a difference. If their SCH is, if their hospital-specific payment is well above the federal payment, it just won't make a difference either way. So why go through the extra effort of documenting the items as well as auditing the amounts for no benefit? So they put in some reasons for it. Maybe they're not the best reasons. I don't really think they are the best reasons. There are things that could happen, but they're relatively obscure or rare and frequently happening. Basically, the rate could possibly change. There might be a reason we would need to go back and recalculate that rate, and we realized there was something wrong with it. So that could, of course, change things. The SCH could lose their status. There are just a variety of things that could happen, but very rarely. So, who knows if they're going to change in the future. This is what they've stuck with for a while. But interestingly, if you look at the S10 instructions, which, by the way, are changing for cost report periods beginning on or after 10/1/22, specifically Exhibit 3C, which is for total bad debts. If you look here, there's an excerpt that says if an SCH is eligible to receive a DISH payment, but E-Part A line 48, which is your hospital-specific payment, is greater than line 47, your federal payments, do not complete an Exhibit 3C listing. But if it's the other way around, of course, you would still need to. So what this little verbiage, by the way, this is the new template that comes into play. And I really should say it already came into play. You've already been filing with this. We just haven't audited this year, and we won't until next year. But the point is, you would not have been required to submit this total bad debt listing as part of your acceptability. It would not be rejectable without it. But at this point, we still have to audit it until CMS changes that, unless they change it. So at that point, if you didn't submit it initially, barring any other change, we're going to have to request that, in February or so when we start next year's audits. So another question that's asked, and it was asked yesterday even, do critical access hospitals have to fill out S10, first of all, or do they have to submit Exhibits 3B and 3C, which are the charity care and total bad debt templates? Now, this one, it's one of those things, I think it's just been overlooked. I don't think it's been changed yet, and it perhaps needs to be changed. If you look at the S10 instructions, they, at the very end of the first paragraph, it says Section 1886D, your acute care hospitals, and cause are required to complete this worksheet. Now, S10, So it was needed back then, even though the worksheet looked a little bit different and it was not audited like it is now. There were audits during the CAW EHR incentive just for that one piece, but it certainly wasn't audited at the level that we're auditing it now for the full S10, almost the full S10 worksheet. So the point, though, is critical access hospitals, they're not eligible for DISH, of course, and I don't really know what, if anything, CMS would use this for. I don't think they are. Right now we have that line, so technically if somebody was to ask, do we have to fill out the S10, my only possible answer at this point would be yes, you do. However, there's nothing in the exhibits or the instructions for the exhibits referencing a critical access hospital, and we're certainly not auditing it as part of the S10 audit. And in fact, if you go into Exhibit 3B and 3C, they're a little bit different. 3B is charity care, 3C is total bad debts. Now, in the Federal Register that we're going to talk about in the next slide, it was very clearly stated that you had to submit your charity care listing, your Medicaid day listing, your Medicare bad debt listing, all the normal stuff. You had to submit that at the time of acceptability, otherwise it would be rejectable. There was no reference to total bad debts, and I think it was just an oversight. Obviously, we need both of these to do the S10 audit, but again, total bad debts, you might just wait and submit by the time we do the S10 audit. The other one had to have been submitted at the time of acceptability. Now, both of these have that verbiage about the E Part A, line 48. If that's higher, you don't need to submit that listing. But notice there's a little bit of additional verbiage for the total bad debt instructions. It also clarifies that IPPS hospitals eligible for DISH must complete an Exhibit 3C. That's not found up in 3B, but the reason is it was already included in the Federal Register. I said this one was left out, so they had to add this excerpt here. But it actually benefits us because it clearly says IPPS hospitals. Doesn't say a thing about cause. So to answer your question about the second piece, do you have to fill out the templates? No. I think this pretty clearly means we don't have to. So you have to fill out S10 as a CAW, but you do not have to fill out the templates, which is good because we're not going to be auditing them anyways. And here is the verbiage from the Federal Register I mentioned, and it very clearly again says DISH eligible hospitals reporting charity care basically must submit the detailed listing of charity care, otherwise it'll be rejected. So that's the summary of all the information there. Hopefully at some point it's all cleaned up and it's all consistent. The next topic I had, though, is with the Exhibit 3A, the Medicaid day listing. It has nothing to do with S10. I just brought it into this discussion to point out that the question is non-DISH acute providers. That same not the same instruction, S-2 instructions, it talks about how the cost report will be rejected when submitted without listings supporting the DISH eligible days on line 24 and 25. So there's no reference right here to it being limited to acutes that actually report DISH. It just says lines 24 and 25, which any hospital can have Medicaid days on line 24 and 25. They may not rise to the level of being DISH eligible. In other words, they need to have a 15% DISH patient percentage, but they still have those days, and arguably it might still be important to review them. So this doesn't really help us any, doesn't give us enough. But if we go to the regulation, again, which came from the Federal Register that we just looked at a bit ago, it very clearly says for hospitals claiming a DISH payment adjustment, they need to submit the detailed listing. So that is the verbiage we need. Usually the policy gives us more detail than the regulation. Here it's the exact opposite, but it's certainly plenty to tell us that if you don't report DISH at that point, you do not need to submit an Exhibit 3A. That being said, you could certainly be amending your cost report later, and now all of a sudden you report DISH. Now all of a sudden you're going to need to submit an Exhibit 3A for the Medicaid days. So it all depends on whether you reported DISH. The exhibit from the S-2 instructions. So yeah, the Exhibit 3A instructions, instead of just general S-2, here it also brings in that discussion about the SCH. So if you have hospital-specific payments that are higher than federal payments, you do not need to complete this Exhibit 3A listing. So that's just the summary of everything we've talked about. So as far as the S10, kind of the wrap up here, we have our normal resources, our GHA website. Well, it's our I should change it. It's no longer, we're not referring to it as GHA anymore. It's the WPS website. But here's the link to it. It takes you to that article. And we also have our YouTube videos where we cover a lot of different S10 issues. We're going to be having new ones next year, partly because the audit itself has changed, but also the cost reporting instructions are different for the next year that we're going to be reviewing. We already have the templates out there, and you've probably already used them for your submissions for this most recent cost report. And I believe we did. We put a YouTube video out there as well. So in our next S10 training, basically our next webinar in February, where we solely cover S10, that's where we'll be talking about all of that. And on that note, next year's audits, 2025, we're going to be starting them sometime early February, at least internally, to get the listing, get the information requests sent out, and have our training and webinar. One thing we're waiting on to find out is whether CMS plans to revise the audit program that MACs have to use, because again, the instructions are a little bit different. The templates are different. They don't have the same fields they did in the past. There are some that have been removed. So our audit program might point us to certain fields that we're supposed to review, which obviously we can't do if the field doesn't exist. So we're hoping CMS just tweaks it at least a little bit. Obviously that'll be on them. And now I want to look at the questions here. Should all auditors have access to the portal for file transfers? The contracted auditors requested data be transferred via secure email. That's not always feasible. And they always ask for data already provided at the time of cost report filing. So yeah, all auditors should have access to that. So the contracted auditors, you're saying some of the subcontractors, that's a good question. They might not, but in any case, if they don't, you could always submit it to one of the core auditors, the true WPS auditors, and we could get that information to them. So they're instead saying they want it via secure email. So yeah, I'm glad you brought this issue up. We might need to have a meeting with them to see, and it might be as simple as we could get them access to that, just like a regular auditor. I'm just not really sure how that's set up right now, but apparently if you're seeing that, they must not have access to it. So I do agree the secure portal is better than some of those secure email systems, because a lot of different companies block those systems. And I know there are plenty of them we can't get into just because of the risk with them. So sometimes the secure portal that you can just go out to a website, log into, it's just an easier system from an IT perspective, security wise. So let me do some research into that and contact the two contracting firms we work with and see if there's something we can work out to avoid that. So yep, thanks for bringing that up. And yeah, your point about the cost report filing. So one of the issues that comes up there is that, and this really could affect all audits of any sort, you file at the time of submission acceptability based on what you have reported there. But a lot of times, think Medicaid days, for example, things have changed, and now all of a sudden you have new Medicaid days. In a perfect world, for like Medicaid at least, you would have submitted an amended cost report and then obviously a listing with it before we do the audit. But for other things, you may not be submitting amendments for, but you do have new data. So that's one of the things, that's our ability, or it's our attempt to allow you to submit the revised listing, and we can audit that instead of having to find out midway through the audit that something has changed and you have more charges or something has changed in general. So that's one of the reasons we still ask for that. Now, of course, if something did change, if it doesn't match the latest cost report we have, we would ask for a variance explanation. And your answer would be, well, we have these new charity care charges we weren't aware of when we filed the cost report. Now we're trying to incorporate them, something like that, and we could include that. So that's one reason for that. And, if there were no changes, you can just refer the auditor back to what was submitted. Yeah, and we'll work more on that with the next year, especially with the other auditors, the contractors. So thanks for bringing that issue up. Now, this topic I did not have in the agenda. It's just a quick slide because we've had this issue come up a few times. We scope one year might be different from what we've scoped in the past several years, really, depending on CMS requirements. They give us the desk reviews, the audit programs, as they find things nationally that they believe are being done improperly. Basically, it's risk assessment is what it is, either done at the CMS level or at the MAC level. If they find things that they're really concerned with, they will often communicate to MACs, hey, keep an eye out for this type of thing. We've noticed a lot of people doing it improperly. So they tell us in some cases what we need to scope. They build in certain thresholds for certain things that tell us what we need to scope. And we have to follow those things. Just because it wasn't scoped in one year doesn't mean it might not be scoped in the next year. But even internally, one of the other requirements they tell us is to take a look at all the things that exceed certain thresholds, for example, and then rank them based on dollar amount, based on impact. Some of those items might get reviewed, others might not. And we have to very clearly document what we do and do not review and why. But also just the overall level of review, whether it was selected for a full-blown audit or just a desk review. And even if it's a desk review, it might be what we call a limited versus a full desk review. That's certainly going to impact the scope of that item, those items, I should say. So the point here is that a particular topic might not be reviewed for several years, and then all of a sudden, maybe in 2025, we're going to review that item. So, and that might lead to adjustments. It might lead to documentation requests. So some of the things we've heard from some providers or groups is that, why are you reviewing this? Why are you adjusting this? It's been quote unquote allowed for decades or several years. And the response is, it hasn't been allowed. It hasn't been reviewed and explicitly allowed. It's just not been reviewed. It's not been adjusted. That does not constitute acceptance of how it was reported. It just means that we have not scoped it for review in the past. Now we need to scope it for review. The underlying rules are there. Yes, there's always that ambiguity in some cases on what that rule really means, what that black and white verbiage really means. But the rule is there, and we have to follow it based on CMS instructions. So the point is, the fact that we did not adjust something in the past doesn't preclude the auditor from proposing an adjustment in some later year when they do review it. And the other thing, though, is it also doesn't preclude reopening of that older year, as long as, of course, it's within the 3-year reopening window. So in some cases, if we find something when we're scoping it in the current year that's maybe a really egregious mistake or a very material mistake, there's the possibility that might lead to, even 3 years of reopenings for that issue. We don't do it every single time we find some little thing. We don't try to look back every time. And that's obviously a heck of a lot of workload. So nobody's saying that happens. But if it's material, if it's egregious, that very well could happen. So there's the possibility. I guess I'll just leave it at that. Now we'll move on to DISH. So we've always got a lot to talk about with DISH. This is the topic that never seems to go away. We have a variety of things going on. A lot of these CRs were public CRs, so providers are probably well aware of it, or your consulting firms, home offices, whatever. So the first one I want to talk about is CR 13294, which was issued back in March 21st of, and I think that was actually February 21st of 24. It's what we refer to as the Alina Part C days. It was effective March 25th, and that one is the right date. So that had really two big parts to it, that CR. The first part was for us to take all the reopenings, the notices of reopening that were issued years and years ago that were awaiting this Supreme Court case decision, which went through a couple different rounds there. And we had to, since the Supreme Court basically remanded that back to CMS to issue a Federal Register, issue a properly effectuated rule, the end result was that what CMS had been doing, kind of informally, if you will, was now what they were going to be doing formally. And what I mean by that is that the Part C days were in the SSI ratio all along, and now they're going to stay in the SSI ratio, barring any future appeals, which they're already ongoing. So what we had to do there was take those old reopenings and issue zero settlements, rather than close them, which would bar any future appeal rights. We had to do a zero settlement to give you a new appeal right. That's part of the Supreme Court communication. Not in those exact words, but that's what they had to do. You had to have appeal rights. So those regular reopenings were completed September 25th. That part's done. That's about the first half of the project. The second half of the project deals with those that were formally appealed and remanded. For those, we had a total of 12 months instead of just 6 months to complete them. So basically we have till March 25th. So, another few months here. Or if the remand had not yet been issued, we would have 6 months from that remand receipt date whenever it happens. Technically that could still happen a year or two down the road. I imagine the board is going to try to remand everything they can to get it off their docket because they can't do anything with it. And then that'll start the new appeal cycle. So the issue we have right now, that is something we just recently were communicated by CMS. We talked about PRB remands. Those come straight to the MAC. There are federal court remands where providers made it up to the federal courts. And when those get remanded, they don't go back to the MAC. They actually go to CMS, and CMS is supposed to remand it back to the MAC. There were some federal court remands from 2021, and they were remanded to CMS. They were never remanded back to the MACs. So they were not part of our initial workload that we were aware of. Apparently those now have been, now they have. Just a couple weeks ago, they were communicated to us. So right now, our question that we're trying to work out with CMS is, when do they expect these to be done? It sounds like there's going to be another workload issued. So we don't really know the due date, but we're going to be working on these to try to get them through. They're all going to be zero settlements, barring any weird issue where something happened at final settlement incorrectly. In those cases, we'll correct it now, and it might be other than a zero settlement. But the point is, the same basic SSI ratio that was available at final settlement is the one we're supposed to be using now. So it should be a zero settlement. Now, I'm talking a lot on this slide about this. I have a few other slides, but I've pretty much covered the Alina stuff now. The next project that's going on right now is 13413, issued in July of this year. And this is the SSI realignments prior to 10/1/13 fiscal year begins. So SSI realignments have been around for almost all of DISH. The first year, maybe two, the SSI realignment regulation wasn't in place. So basically this goes all the way back to, I think it's 87. I think it's where it started, maybe even 88. I'll see it in the next slide here. Now this is, these SSI realignment requests for the workload purposes, MACs have 24 months from the receipt of the request to complete it. Now, although that might sound like a lot of time, there is a lot that goes on behind the scenes with these. Again, these can go back to the mid 80s. And one of the biggest problems we face is finding those very, very old files presents a problem right there. So that's the first step, is just finding the file. The very, very old ones, we don't have HFS or any software that would work them. It doesn't run on a new modern system. It just flat out doesn't. So a lot of these are going to be more manual, which I'll talk about in the next few slides in a bit here. So this was the Part C day issue. Again, I kind of set the stage for the two topics. Now we're back to some more of the detail of the Part C. And here's the link to it, by the way. So what the Supreme Court basically said in their remand was that CMS needed to go back and properly issue a final rule, which they did. And there was no rule prior to their first attempt at 10104. There was no rule. So CMS, the basic appeal was that CMS didn't properly effectuate that rule to include Part C days in the Medicare SSI ratio. But again, prior to 2004, nothing existed. So when they issued this final rule on 23, really the only choice they had was to retroactively make a rule. Now, they were on the side of including Part C days in the SSI ratio, but even if they went the other way and said, well, let's put them in the Medicaid ratio, again, it would have still had to be a retroactive rule to make sure all the years are covered and consistent. Now, again, the rule is that the Part C days are in the Medicare SSI ratio. They do have a proper rule that took place 10/1/13 and after, so that one's less contentious. But this retroactive rule covers all the years that Part C covers, which is back to 99. That's where Medicare Advantage, you can see those days there. So again, all these cost reports were originally finalized with that type of SSI ratio with Part C days, and now we were just making sure to use the same thing for those zero settlements. So we've covered all of this piece. Here's just a link to our website that covers those articles. And yeah, all of that. Same thing there, zero settlements for the most part. So now on to the SSI ratio realignments. The more detail there, kind of jumping around a bit. My apologies for that. This one we actually do have a little bit of more information on, and I want to get into some of the details here about this SSI ratio in general. If you look at the definition of it, the numerator of the SSI ratio is going to be the number of days related. And again, I shouldn't use the word entitled there right now, but they have to be entitled to Medicare Part A and covered or paid by SSI, Supplemental Security Income, those benefits. So they have to be both. And that's divided by just the patients entitled to Medicare Part A. So as you'll notice here, the issue is, again, Medicare entitlement, but I just said SSI coverage or payment. That's actually a brand new, fairly new Supreme Court case. They just heard it a while back on that part of the Medicare SSI ratio. Everything up to this point has been this whole entitlement issue for Part A. The Alina Part C issue rolls up into that. Are they still entitled to Part A? The whole total versus covered from the old CR 9311 years ago, that rolls up to that same issue. If they're exhausted benefits, are they still entitled? And that's kind of what we're talking about here. But again, now we have a new Supreme Court case that's covering this aspect of it. It's been heard. It hasn't been decided yet. We'll be interested, obviously, to see what that decision is. Now that, potentially, let's say the Supreme Court finds adversely to CMS, that could potentially impact every single SSI ratio out there, all the way back to the beginning, all the way till today, because SSI coverage has been the key to that. Now, we don't know how narrow it would be. Even if it was adverse, would it be limited to just the providers that appealed it? All that is unknown by us. But I just wanted to bring up the issue there. Now, let's talk about the SSI realignment itself. By default, an SSI ratio is calculated based on the days in that federal fiscal year, regardless of when the provider has their cost reporting period. So more specifically, for that cost reporting period, the SSI ratio you're going to be grabbing is the federal fiscal year that the cost report begins in. That's how you match it. This link down here takes you to CMS's DISH section of the website. And here's the regulation, 42 CFR 412.106B3. This is the regulation that came in just, again, a couple of years after DISH started. And it says that if the hospital prefers that CMS uses the cost reporting period instead of a federal fiscal year, it basically must request it to the MAC, and then we'll go to CMS with it. It can be performed once per cost reporting period, and the resulting percentage becomes the hospital's official Medicare Part A SSI ratio for that period. Now, this regulation is separate from reopenings. There's a reopenings regulation, then there's this. This has no reference to a 3-year requirement. And as we'll see in just a bit, there is no longer a 3-year requirement for SSI ratios. That's the main purpose of the CR 13413. Just quickly down here, I have an illustration about, the two options. Federal fiscal year alignment, we're using days from 10/1 through 9/30. And you can see each month is going to have a different mixture of days, Medicare and total. If they realigned, if they had a 12/31 period, they're using 1/1 through 12/31, which again, each month might be a little different. It might benefit them using the federal fiscal year versus the cost reporting period. Some providers might benefit from that. Others might benefit from their actual cost reporting period. Moreover, every year is going to be different potentially. This provider in this year was better off realigning. They have a higher SSI ratio. Next year, it might be the exact opposite. So every provider has to look at every year to see what benefits them the most, if at all. That's the other thing I want to mention. If you're capped, for example, if you're already at the 12% cap, a higher SSI ratio is not going to help you, assuming you are not exempt from the cap to begin with. So an SSI ratio increase might not do anything for you. It might impact capital dish. If you had capital dish, that might still be beneficial, but it wouldn't benefit operating dish. The other side of that is if you're below the 15% threshold, again, assuming that threshold applied to your provider type and situation, if you're well below 15%, maybe a percentage increase on your SSI ratio, you're still going to be below 15%, so it's not going to help your operating dish. So for that reason, it's important to understand, will an SSI realignment, first of all, is it going to increase so it potentially benefits you? But second of all, does it really benefit you at all? There's nothing, I will say this, there's no requirement right now that there has to be a materiality impact for us to do the SSI realignment. That's different than most reopenings. So what I'm saying is any SSI realignment request that comes in that's properly formatted, as we'll see in a bit, we have to complete, we have to settle. Whether it's a zero settlement, an increased settlement, or unfortunately, if you requested a realignment and that realignment was actually lower than your federal fiscal year, we do have to do that as well. So hopefully you take a look at that spreadsheet and identify whether or not it even benefits you. Now, in the past, we used to have to submit these to CMS to get the SSI ratio, and now they have actually given everybody a listing of what the SSI ratios are for the old ones, for everything under this CR 13413. For the newer SSI ratios after 13, they're still following the old process. You submit a request to us, we send it off to CMS, and we have to wait for them to give us the SSI ratio. I don't know if they're going to be using this same spreadsheet idea for the newer ones or not, but right now there's no other CR. So there's a split between the two periods, before 10.1.13, after 10.1.13. So as far as the request, it's pretty straightforward. I think I already talked about this. Yeah, here's the exact date when the realignments became effective. It was 10/1/1987 fiscal year begins, and DISH technically started in 86 for those years, so a couple years there. No time frame anymore for submitting an SSI realignment request. If it is within 3 years, it's just a normal reopening. We'll refer to it as a reopening. If it's beyond 3 years, we use slightly different terminology, but it's the same effect. We call it a revised settlement instead. Here's the DISH section of the website with, again, those different articles. CR 13.4.13, for the request, you first of all submit it to this email address or my individual email address. And three things it needs are the provider number, fiscal year begin, fiscal year end. That's all you need, and it needs to be there for every provider you include. You can have multiple providers in one request. That's perfectly fine. I will send out a confirmation email when we get it. The thing about that is you also don't even need an attachment. It doesn't need to be in a formal letter format. Just the body of the email will suffice. Either way is fine. Now, I talked about the due date being 24 months, and I think I've already mentioned this, that we obviously have several of these different SSI CRs out there for a variety of reasons, but finding and reconciling those old files is really the big bottleneck, and we're working certainly as hard as we can on that. Some of them we have to order hard copy files. We've actually requested we've requested providers, if you happen to have it, to send it in. So if you see an email from us just asking, if you do, that's great. If you don't have it, just let us know, and we'll work on the next option we have. Some of them we've had to actually input into the HFS system because for some of the situations and some of the years, CMS requires it to be an HFS, to be an electronic file. So there's just a heck of a lot of work that goes along with that before we can even do the DISH calculation and settle it. That part actually doesn't take that long. But obviously there's a huge quantity of them. So let's see. This is the other thing. I got into the discussion about that Supreme Court decision and how it's impacting the SSI portion of the SSI ratio. So I'm aware that some providers are holding on to those SSI realignment requests until that Supreme Court decision is made. I think there might be a little concern amongst some of the providers that what if that Supreme Court decision is adverse and all of the data is going to change anyways? I think there's a concern that they didn't want to lock themselves into something and not get the benefit of a new ratio if it's better. And and of course I can't provide any 100% assurance, but I just really don't see CMS going that route because that's just going to open up another appeals avenue down the road. So I think we're certainly going to be settling these SSI realignments. And then if something were to happen, it's going to be another change request and we'll go through the same process again. If you requested an SSI realignment before, I'm fairly confident that you'd have the ability to choose yes or no under the new data because, the new data could change things. Maybe the SSI realignment benefited you before, and now a federal fiscal year alignment would benefit you under the potentially hypothetical new data. Again, I just don't think it's a concern. I really would be very surprised if CMS tried to hold a provider and lock him into something that the new data would change. That's just my thought. So we don't, of course, know about this. It's probably going to be I don't know when we're going to hear the decision, first of all, and then when it'll be implemented if it's adverse. But in the meantime, basically, feel free to submit those SSI realignment requests. We're going to go ahead and settle those. Although I will mention, though, out of all these workloads we have, the remand piece of it due by March 25th, that has to be our priority. And we are working on those. We still have a fairly high number of those. So we've been working up the SSI realignments, and a lot of you have already received the adjustments and accepted them. But the back-end settlement piece, that might be on hold just a little bit because we have to focus on the remands first. So again, even though we have the 24 months, we're absolutely not trying to push things to 24 months. So don't think that. But from now till March, basically, whether we get any SSI realignment requests settled, that's kind of up in the air. We may, if we have the ability to get some of those through, but it's all about bandwidth and how much we can get done in a particular period of time. So just wanted to mention that. After that period, we're going to be moving completely over to the SSI realignments. So more of them will come in around that time. Now, the next topic here is the low volume payment. Here's the regulation for it. It's actually been around for a very long time, but for the first large part of its life, very few providers ever qualified for it prior to fiscal year 11. In fact, fewer than 10 hospitals nationally qualified for that because it's extremely stringent. You have to be located more than 25 road miles to the nearest hospital and have fewer than 200 total discharges. So that's extremely low volume. And the new provisions that have been in place since 2011 extended multiple times up until 12/31/24. Now you only have to be more than 15 road miles to the nearest IPPS hospital and have less than 3,800 total inpatient discharges. By the way, when I say IPPS here, again, I'm not talking Medicare. These are total discharges. IPPS inpatient is just basically showing you they're the type of discharge that would normally be paid under the Medicare IPPS system. So that type of discharge. Specifically, it's on S-3, line 1, column 15, based on the most recent cost report that was submitted by the time you made your attestation submission. Sometimes we get a question about whether we can use a newer cost report now that one's been filed. The answer is no, that payment is locked in as of the attestation date. It's never updated. It's a prospective payment. Now, right now, on that note, since these expired 12/31/24, I recently sent out emails to all the low volume contacts we had saying that based on CMS instructions in the Federal Register, a new mileage attestation would be needed for the 1/1/25 through 9/30/25 portion of that period. That's assuming Congress extends this and then whenever it's implemented. So that attestation was needed, but the same cost report data is going to be used. Based on our current understanding from CMS, they're not going to split the year and have two different payment percentages. HFS cannot even handle that right now. That's not built into the cost report to allow that. So I'd be very surprised if CMS allowed for a different discharge count to be used for different periods of the calendar year. There's obviously a split if you have a different cost reporting period. If it spans 2 calendar years, of course there's going to be a split for those 2 calendar years. But within a calendar year, there's no mechanism for a split. So that's my point there. And again, this right now, it's set to expire 12/31/24. So we're not sure what CMS or what Congress is going to do. There's already some legislation, not a bill, let's say there's a bill in place. We don't know when and 100% for sure if it'll be passed, but I strongly assume it will be. It's been that way for multiple times. So we'll wait and see what Congress does. And then even if they were to pass it by 12/31, CMS still has to implement it. And that takes, a month, a few weeks. So what is almost guaranteed to happen. I'd be extremely surprised if it doesn't. This will terminate 12/31, so your claims 1, 1, and after won't have low volume, but then at some point, most likely it's going to be implemented and it'll be retroactive like it has been in the past. So we'll have to reprocess claims. Again, no guarantee on that. It's all dependent upon what happens, but that's my thought. Now, of course, if you did qualify, if you're a provider right now that is going to be terminated 12/31, but if you meet the old criteria, the less than 200 total discharges, you can certainly submit that request and your low volume will continue on without interruption. We just, as you see here, we have very, very few that are that small and low volume. Here's the bill that is out there, Preserving Telehealth, Hospital and Ambulance Access Act. There might even be others out there that are pieces of other legislation. There's no update at this point, although some of the websites I looked at, political websites, basically said this is kind of one of those must-pass type things. It's got to be on Congress's last-minute to-do list, so who knows what'll happen. Now, as far as the payment, it's a sliding scale, a sliding linear scale. So the fewer discharges you have down to 200, the higher the payment adjustment's going to be, up to the maximum of 25% add-on, which is a very generous add-on to your normal federal payments. Now, if you have close to 3,800, which is the max number of discharges, of course, if you have over 3,800, you're not going to qualify. But let's say you have 3,799, you're going to get a very minimal add-on, but something's better than nothing. And here are the different final rules about that. Yeah, same attestation process. And here are the 2 email addresses to send that to, and we will send out the letters once they've been completed. We do that in bulk, so it's not like FIFO type of thing where the earliest submitters get the letter soon. They're all going to be sent out at the same time, just for administrative efficiency. So we talked all about that. Now we'll move on to the next. Let me see if there are any questions here before I move. Okay, we're good to go. So the next topic is really just a cost report flow refresher paired with a discussion of cost center assignment, grouping, and allocation. Now, I'm going to go through some of this pretty quickly. We give this to our auditors quite a bit, our cost report flow training, so they're aware of how everything works. But we're going to talk about just the core flow from worksheet A to the E series. And for worksheet A, this is your total costs for providing services to all payer types, all patients, and it's your working trial balance with some adjustments, with some reclasses to match the Medicare rules of accounting. So again, it's all costs. It's not just Medicare. We have reclasses on A6 and adjustments on A8 to get costs into the proper format, again, based on those Medicare principles of accounting. There are certain things that are just not allowed for Medicare, even though they were on your working trial balance. And there are other things that might not have been on your working trial balance, but are allowable costs. Home office would be a good example of it. You might not have had that on your general ledger, but it's a cost that is allowable for Medicare and it can be added in. And the other thing is most of the fee schedule costs are not allowable on the cost report because they're not reimbursed under any DRG type payment. And CMS uses this cost in part to help develop the DRGs and the various factors that go into federal payments. So I like to refer to this as comparing apples to apples, or really taking a basket of apples, the total costs, and trying to pull out just the Medicare apples. That's maybe a way of putting it. Now, again, we do this through the cost report flow, and worksheet A is the starting point to identify the total amount and adjust it and reclass it. Worksheet B, this carries over the total costs from worksheet A at the very end. And all of those costs have been directly assigned to various cost centers. Some of them went to overhead cost centers to start with, and some of them went to various departments like the operating room, the adults and peds, the ICU, lab. So you knew where those costs went. You grouped them there is the proper terminology, and they've been assigned. So worksheet B, the whole point is to take those overhead costs or general service costs and allocate them down to the revenue producing cost centers, or profit centers is another term for it. That's basically your departments that actually have both revenues and costs. Now, internally, you're already doing this for your own managerial accounting. You want to know how profitable each of your departments are. That helps you set your prices. That helps you manage your cost. For Medicare purposes, we need that data, or CMS needs that data, to help set rates to make sure they're paying a proper rate. So again, we want to find out how much it costs to really provide a particular service, both the direct costs and the indirect costs. Now, we'll get into worksheet B. Basically, it allocates the cost. If you've had accounting before, it's activity-based costing is essentially what's going on in the worksheet B and B-1 series. They're taking the overhead, finding the proper place to put it, and then we're going to use that in the next step, the worksheet C, to basically take that cost for each cost center, each department, if you will, compare it to the charges for that department, and try to identify what's called a cost to charge ratio. So we're trying to, again, the important thing there, which we'll get to in a bit, is to match the way that the costs were grouped into the various cost centers with how the charges were grouped for those same cost centers. By doing that, we can compare how much charge related to the underlying cost to determine essentially what type of markup existed in that department or that cost center. So if you have a cost center, a department, or a particular service where the patient was charged $1,000, or that was the total charge, I should say, but the actual cost of providing the service are only $700, well, there's a markup of $300. Now, this is just a completely generic example for simplicity. But if you look at the inverse, instead of looking at a markup, let's look at the inverse of that and get a cost to charge ratio that basically says for any charge figure in this department, apparently 70% of that is cost. So now we know that any charge can be multiplied by 70% to get the underlying cost on average. That cost to charge ratio that we get in worksheet C is used for one of the two apportionment methods in just a bit, which takes us to worksheet D. It has a lot of different worksheets related to it, but the whole goal of worksheet D is using one of two methods. We're trying to find out how much of those total costs are really related to Medicare services or Medicare patients. That's the goal. So there are two types of apportionment depending on the type of service. There's ancillary apportionment and routine apportionment. Ancillary apportionment uses what we just used, the cost to charge ratio. Basically, we're saying the relationship between total costs and total charges, we're going to use that relationship to find out how much Medicare costs we have. It should be the same relationship between Medicare costs and Medicare charges, the same cost to charge ratio, essentially. We know Medicare charges easily because you've been billing them. We have the PS&R. We can use these Medicare charges for each cost center, multiply them by their respective cost to charge ratios to identify how much of that charge was cost, which, again, that's what CMS needs. For some provider types, like a critical access hospital, that's what determines your actual cost reimbursement. Other provider types is just data that's used to set future DRG rates and other things. And this is just more of an informational slide, really to show how that relationship, that seemingly simple apportionment methodology, is actually pretty strong because there's really no good way to manipulate it without hurting yourself anyways. So that by using that total cost to total charge relationship and applying it to Medicare, it's a pretty strong apportionment. It's hard to defeat it. Now, the routine side of things, and this is your adults and peds, your ICU, it's just the fact, it's the room and board. It's the fact that a patient's in that area for a day, getting the general level of care that one would expect in that area. So instead of trying to figure out the relationship between charge and cost, we assume that every day should on average be the same. So the relationship now is total routine costs to total days. Divide them by total days to get an average cost per day for that particular cost center. And then we use that cost per day to multiply by the Medicare days that you've billed for to find out how much of that cost is Medicare. So just quickly, why use two apportionment methods? Again, ancillary charges or ancillary services, you have separate charges for. That's by their nature. Routine services, you're charging for a bundle of services given on a day, just the room and board essentially. So there's just a different relationship. It makes sense to have them separately reported. For example, one day with ancillary, a particular patient on day one, let's say, may not have a whole lot going on. They're in the room. They're just getting ready for some of the services that they might need. Day two, all of a sudden, they have a lot of operations, a lot of lab, drugs, things like that. So ancillary does not work on a day-to-day basis. It works on a service charge by service charge basis. Now, that was all cost report flow. And this leads me into really the important things from a provider perspective, that categorization is the key, or grouping is the key. That's a decision made by each provider. They have their own accounting system, their general ledger, and all those accounts need to be mapped or grouped into the specific cost centers on the cost. Every provider has a different accounting setup. Some of them are very, very complex. Some are not as big. They don't need to be as complex. But the cost report has a fairly set number of cost centers, and it's virtually guaranteed to be simpler, smaller in number than a hospital's accounting system for both revenues and expenses. So you need to categorize them into the cost centers, but the point is they have to be grouped similarly. So if a particular expense relates to this cost center, then any related revenue for that service needs to go to the same cost center. Obviously a different worksheet, but the same cost center. The way you communicate that grouping to us, it's actually twofold. You have an expense and a revenue grouping schedule that, depending on the level of review, we might be requesting that from a provider. But there's also the provider crosswalk that tells us how your Medicare charges were billed and how to group those back into those same cost centers. There's a little bit different terminology there. We talked about accounts for the costs and revenues, but the items you billed, the terminology there is actually revenue code. That's how you build them. So those revenue codes need to be grouped into the related cost centers as well. The point here is all three things need to be matched up. They need to be consistent. Your total costs, your total charges, those use the account to cost center grouping. Your Medicare charges use the revenue code to cost center grouping. They have to be similar. And yeah, so that's what we talked about there. Now that leads me to another issue that's come up a little bit lately, related to a level 1 edit that'll pop up on the HFS software or just any cost report. This happens when a particular cost center, if you look at the Medicare charges that were brought in from the PSNR to that cost center on your D series, and if you compare them to the total charges for that same cost center on the C series, worksheet C, worksheet C is total, and it makes no logical sense whatsoever that Medicare charges can exceed total. Just not logical. So this level 1 edit pops up when that happens. It just, again, it makes no sense. So that tells us something is wrong here. It's possible that your total charges were put in the wrong cost center, but that's not something that would be visible and transparent to the MAC. We reconciled to your revenue grouping schedule, and that's how they're listed. So if you made a mistake in your grouping schedule, of course, you could correct that. But what's more likely to have happened is that your mapping, your crosswalk from the PS&R charges, PS&R Medicare charges coming back to worksheet D, that might have been incorrect. So what'll happen is if we see this level 1 edit, we're probably going to be, if it's something we can easily identify where it should go to, then we can make that change. But our second level would be to go back to the provider to say, hey, where should this go? It can't fit in here. There's not enough total charges for it. Does it go into another cost center altogether? Or if you tell us that you did make an error with the total grouping schedule, we can tweak it then if it's logical, if it makes sense. And it's possible that something might have been mapped incorrectly between inpatient and outpatient as well. So the point is, we'll be asking you that question and we'll need a response in order to move forward, because we cannot settle a cost report that has a level 1 edit. So that's the thing I wanted to mention there. It comes up every now and then. We can't just blindly adjust total charges to allow for that room. We just can't do that. That's a CMS issue. Let's see, so we have that. What did I miss there? Same thing. Now, to wrap up this whole cost report discussion, I want to really focus on the importance of data. Some of this stuff might not seem important to providers, and it might not seem important to auditors as well, depending on the type of hospital you're dealing with. For example, for critical access hospitals, it's extremely important. All those things matter. Everything we do in worksheet A through E, well, through D, I should say, is going to impact your cost reimbursement. Now, for PPS hospitals, there could be some cost reimbursement impact if you have a cost-based sub-provider like an RHC, or even if you just have a cost-based pass-through like nursing and allied health, CRNA, organ acquisition, and to an extent, even GME. And that's related to how it's apportioned between Part A and Part B. It doesn't impact your total amount, but it impacts what side it goes on. But the point is that cost reimbursement will impact some of the reimbursement, or that cost data will impact some of the reimbursement to a lesser extent than the CAW, but still it's an impact. Even those facilities that have zero cost-based reimbursement from any type, we can't just say throw whatever you want on the cost report. CMS has reiterated multiple times, but the cost data is important to them. They use it to set rates. Now, they don't have us generally do a full-blown cost audit if there's no reimbursement impact. There's always that potential, but it's unlikely. But still, they want to make sure the cost data is proper. They do have us do certain steps in the desk review to kind of identify things that just don't seem right, relationships that don't seem right, increases or decreases from prior year to current year that don't seem right. And in those situations, we might be asking for variance explanations. And we're just looking for something to make sense out of it. Cost report, it starts with a variety of standard cost centers. You might feel the need for more accuracy to expand that cost center list. For example, you might have a newer office building and you need to subscript one of the capital cost centers to be able to split your capital into two pieces: older stuff, older buildings, versus a brand new one that only certain departments are using, for example. And the cost structure is different with a new building generally. You might be fragmenting A and G. There might be a variety of different things you fragment for various reasons. That's a unique cost center, and you can just request that and just show justification for why you think it's going to be more accurate. Another thing you can do is, this is more stringent, but you can request a direct assignment of overhead costs. In other words, bypassing the B-1 step down. And this is a situation where you have to have good auditable documentation for how you know that overhead cost goes just to this one cost center instead of being split out across all the other cost centers. A great example might be electricity. You might be able to have separate metering in different departments to identify just how much electricity cost goes to each department, instead of using some fairly arbitrary statistic like square footage under the operation of plants cost center, overhead cost center. And you might have a change in statistical basis. Maybe you've used movable, or you've used dollar value as your capital statistic, and now you want to use square footage, or vice versa. There are just a variety of things you could change. Just like the unique cost centers, you have to justify why it's going to be a more accurate allocation. Or there's also the option to request it due to simplicity. It's easier to maintain this statistic, or you can't maintain the old statistic anymore. That's a possible request. It's called the simplified cost finding method. And then back to what I was saying a bit ago, explanation of variances. This is a request from the MAC to the provider, and we're just saying we found issues that exceeded certain thresholds and we need an explanation. Now, I went through those requests very quickly because it's more of a refresher and it's more of a tie-in to what we've just been talking about. But we talked about these in more detail in prior webinars, first of all, but also we have this link to our website. If you look under cost, statistics, and charge issues topic, then it actually, first of all, we have a YouTube on the topics. We also have information on how to request it, what's needed, all of that. I'm opening up that website here just to show you that. And if you go to the cost, statistics, charge issues, you'll see we have the grouping requirements, direct assignment, variance analysis, Medicare charge allocation, the crosswalk. This one doesn't belong here. It needs to be moved. We'll actually talk about that in the capital section. Changes in statistical basis, routine versus ancillary, a lot of different things here. And a lot of them have YouTube videos covering the topic. Now that takes us to the E series, which I'm barely going to touch on. That's where everything rolls up to. The E series would be the settlement worksheets. Depending on what provider type you are, E Part A is a pretty common one for the acute cares. If you're a psych, you're going to need E-3 Part 2. Cause have E-3 Part 5. And most of them have E Part B. That's your outpatient side. So that takes us through the cost report flow portion of the training and all the stuff that rolls up to that. Now what I wanted to do is give just a fairly quick refresher on nursing and allied health. The core regulation here is 41385 D2. It shows a couple of things, and then kind of this middle thing is, I guess, more obvious. But to be allowed for cost reimbursement, which is what nursing and allied health is, the program has to be operated by the providers. There's an exception to get you partial reimbursement we'll talk about, but generally it has to be operated by providers, not some other educational institution or the home office or anything like that. It has to just generally enhance the quality of healthcare at the provider, which is kind of an obvious one. Medicare wants to reimburse for things that are related to healthcare, that help improve healthcare. Training and education can certainly do that. But of course, to be allowed, you have to meet licensing and accreditation requirements. It's a fairly straightforward one to review, but it's definitely a necessary one. It has to be a valid current accreditation. So if you qualify for this, the underlying costs on the cost report are allowable as pass-through and cost reimbursement instead of just being rolled up through DRG payment. The costs are initially reported on worksheet A lines 20 and 23 in any subscripts. The first major classification you could bring up with these types of costs from a training program are classroom instruction, known as didactic, versus the actual on-the-job clinical training. That's what they're actually going to be doing, and they need to see it in action. So those are the two types of categories. And this dissection there is important because depending on whether you were actually operated, whether the program's operated by the providers or not, you may or may not get both of them. In other words, you may or may not be eligible for classroom costs. Now, I do want to bring these two topics up. These are at the very top of the regulation, and they've been important in many CMS discussions and appeals. So I wanted to kind of define them. So if you hear these terms, you know what they're related to. Community support is the first one. And the underlying idea, the initial idea with nursing and allied health funding from Medicare under Title 18 was that Medicare was going to kick in the funding until such time that the community for that program had taken over funding, whether that be the state or local government, a variety of other things, other than grants, gifts, and endowments. They're not offset. So CMS's thought is that eventually down the road, they assume, back in the 80s when this was first developed, they assumed that the communities across the country would be taking over the support of this. That, to a large extent, has not happened. To some places it has. So they hinge a lot of their discussion on this. They want to make sure that community support has not yet kicked in before they'll reimburse for it. The redistribution of costs is another thing that CMS thinks that at sometimes it might happen. Not always, but in some cases it happens where the costs are now redistributed to an educational institution. They're operating the program, they're incurring the costs. Once this has happened, it's a one-way street. CMS's thought is that this can't go back. Once it goes out of the provider to some other entity or is funded by some other entity, Medicare is no longer going to kick in the funding for it. So that's what these two aspects of the regulation relate to. The other thing about this is that the cost has to be offset by any related revenues, which would generally be tuition and student fees. We have a website page that goes through tuition offset. And here's the excerpt from the regulation. The net cost of approved educational activities is determined by deducting the revenues from tuition that are directly related to approved educational activities. Now, here's the piece I want to mention. That term directly in cost accounting takes on a separate meaning than really what CMS, they meant it more generally here. When we think of direct costs from cost accounting, we're generally talking about non-overhead costs. The ones that we know go to that particular cost center, we're excluding overhead. That's not what they meant by this. They meant that, hey, these costs have to be actually education related as opposed to something else. So whether it's indirect or direct cost, as long as it relates to educational activities, that's going to be allowed, and the tuition has to be offset from both of those types of costs. In other words, we're not offsetting revenue against any other cost center. That's the point. If you happen to have excess tuition revenue well above your costs, sometimes it happens, most of the time not, we're not going to take that excess revenue and offset it against other Medicare cost centers. That's the point. Right now, the requirement that CMS has hammered down is that we have to use A8 adjustment to offset the total tuition revenue against the line 20 or 23 cost centers, whichever one they relate to, for that program. Now, if there's excess, keep in mind A8, at that point, we just have direct costs. The B series is where we get the overhead costs. So if there's excess revenue above and beyond the direct costs, that carries over and starts to offset the indirect overhead costs as well. If at the end of worksheet B, there's still excess revenue, that just drops off the cost report. It doesn't go anywhere else. It doesn't hurt you anymore. So that's the tuition aspect. The next piece is that provider operated status. Is it the legal operator or not? And this has gone through, we've had quite a bit of education on this in the past, both from CMS through a CR, as well as the things we've built internally at WPS. But this CR going back to 2018, CMS really strongly wanted us to ensure that we're looking at this in depth. So they reiterated, that's the term I'm looking for, they reiterated what the regulation said so that everybody, both providers and MACs, were aware of what the requirement was supposed to be. Regardless of some kind of ambiguous and kind of weird verbiage in the regulation, they wanted to be very clear on what the requirement was. Our Nursing and Allied Health Review questionnaire, linked down here, goes through those steps. It's a good way to document what your program has so that we can review it. Here's a link to our YouTube video that covers all this as well. And if we go through this regulation, here are the 5 pieces that must be met. The provider, as opposed to some other entity, in other words, no home office, no educational institution, so the provider must directly incur the training costs to be reimbursed for them. They must have direct control of the program curriculum. And what they're saying is there could be an educational institution first furnishing basic courses, but the provider must control all the clinical theory courses. So, if we're talking gen eds, for example, hey, that's fine if you outsource those, but the clinical stuff has to be controlled by the provider. The provider must control the They must employ the teaching staff. That's a very clear one. It's come up a few times. And they must, we already talked about the administration of the program and the program curriculum. Down here, they hit on that even further. The provider must both provide and control both types of training. Again, there's that, it refers back to the basic academic courses exception. I don't really know why they hit it 2 times. It's the same essential thing. Now, the confusion has come up from this last paragraph. This is not a one that shouldn't be there. It's just a separate paragraph. It says, absent evidence to the contrary, in other words, no, to the contrary, the provider that issues the degree, diploma, or other certificate is assumed to meet all these criteria and be the operator of the program. This was interpreted for a while to basically say, hey, if you have a degree, we don't care about any of these things. CMS absolutely did not mean that. And they basically said, you need to focus on this absent evidence to the contrary. You're never going to get evidence to the contrary if you don't review it. That's kind of what their thought was. So, this really, maybe a better way to put this would have just been call this item 6. Hey, you also need to issue the degree, diploma, or certificate, instead of this weird verbiage. But regardless, CMS was very clear that all 6 of these items must be met to be the operator of a program. And if you're not the legal operator of a program, you can still get some reimbursement potentially, but it's going to be limited to clinical training costs. None of the classroom costs will be allowed. Now, if you go to the regulation related to the legal operator or the non-provider operated requirements, it says, first of all, obviously you're limited to just clinical, but even then that's limited to a ratio that was built in the 1989 base year cost report. So what it says is, in any cost reporting period in the future, from 89 on, the percentage of total allowable provider cost attributable to clinical training cost in this current year cannot exceed that same ratio from 1989. Now, obviously, the dollar amounts of both are going to increase dramatically from 89 till today. That's just inflation in general. But the percentage, so the relationship between the clinical and total costs, cannot exceed it. Now, the way that was written is kind of weird because it's actually a criteria. If you read the whole regulation, it's built as a criteria for being allowed any clinical training costs. So it almost seems like, hey, if you've exceeded that percentage, you're done. You're not getting a thing. It's a cliff, so to speak. Fortunately, if you look at the Federal Register from 2001, they clarified it that was not intended to be a cutoff. You're done at that point. It was just a limit. You're only going to get that percentage that you had in 89, and that's it. So that's what we have there. Moving on to the, that. Moving on to the managed care add-on. Just going to briefly talk about this. There were a lot of things that happened in between 2020 and 23. The original calculation, the original factors came out in 2003 for CR 2692, and they were supposed to be updated annually. There were the factors that helped us to divvy those up that were supposed to be updated. And there's a reduction to your GME payments that basically funded the pool. That was supposed to be updated as well, right alongside of the pool. Those were never updated annually. And then eventually in 2020, I think through some various appeals and communications, CMS realized they had to update those. So they updated them in CR 11642. And we made payments at that point. And then they continued to be updated at that point. But then there was some legislation passed by Congress that said, hey, this $60 million payment pool limit that was put into place by the original legislation, it's severely outdated. And they said, let's go ahead and adjust it to a higher amount. But the legislation only impacted 2010 through 2019. So with this CR 13122, we had another reopening project where we revised payments for every reopenable provider at that time. The problem is, even though the pool was higher, these new factors and the GME reduction, in the end, it was a detriment to providers. It reduced the nursing allied health add-on payment for providers. That was not the intent by any means of the legislation. And through, again, some communications and appeals, CMS changed that through CR 13337. And they basically said, well, you know what? The original calculation was actually higher. The legislation that was enacted was never intended to reduce payments. So what we're doing now is reverting back to the original 2003 calculation because it's higher. Essentially, whatever money was pulled away in the reopenings from these two CRs is now given back to you, but it restores you back to the original nursing allied health calculation. So this CR, we had to go through the effort of showing the payment under the different scenarios and showing that old payment was higher, and that's what you received. But keep in mind, that stopped at 2019, barring any future legislation. 2020 and after do have new factors and a new pool number. We have a spreadsheet, a calculation that we have loaded to our website. We have a YouTube video talking about all this stuff that I just talked about in more depth. The one thing I will say is that I do need to update this spreadsheet to include the newest 2023 factors. Right now, it stopped at 2022. So that's on my to-do list to do. So that is the nursing and allied health refresher there. Again, those YouTube videos spend a lot more time on each of the separate issues. This is just intended to be a refresher. This is a brand new topic that we have not covered before. We don't have a YouTube yet, but there is going to be one out there. That's on my list as well. So all-inclusive rate providers, just to give you this excerpt, this discussion, certain providers bundle a lot of different services into one overall charge. They don't have a charge structure that would be matchable to cost centers. They don't have a way of breaking it out. And CMS has said, even though that's not preferred, we'll give you that exception. That's the way you operate. You have to request it and be approved for it. And then you report it on S-2 line 115, which of the methods you're using. Again, all the definition for this is found in the PRM 15.1, Chapter 22, Section 2208. That's where you get all this detail. The reason we're even bringing this up today is that it appears like CMS, at least for one provider type, is trying to get away from those all-inclusive exceptions. Right now, it's only for the psych hospitals. They issued guidance on October 10th. And here is the link to the CMS website that covers this guidance. And specifically, psych hospitals will no longer be allowed to report as an all-inclusive rate provider unless they're a government or tribally owned facility. That is technically effective for 10/1/24 fiscal year begins, which obviously we're already 2 months into that. And even their guidance was 10 days into that period. So there's a list of 122 providers that are accepted. They're government or tribally owned. Now that list could expand as we find more, as more providers show ownership documentation that they're government or tribally owned. This CR that was issued, this communication that was issued required MACs to reach out to those providers that were reporting as this, but were not on this list. Basically, first of all, to find out, hey, are you really a government or tribally owned facility? If so, just prove it to us, and then you'll be on the list. You'll be fine. Otherwise, it's more of an educational item to let you know that you need to set up a charge structure for cost reporting purposes. You're no longer going to be allowed that exception. Now there is, because they were a little bit late in the communication, they've allowed a temporary exception if you can't set it up yet, but the absolute end date of this exception is May 31st, 25. Even if that's midway through your cost reporting period, you're going to have a split. The first part of your cost reporting period might be accepted if you were approved for it, but the last part of your cost reporting period must be under that charge data. Because again, we talked about the apportionment and how those charges are necessary to get a good idea of Medicare cost. CMS just does not want to go off of these less sophisticated methods anymore. For psychs, I don't know if they're going to go and expand this to other facilities. I don't really know what is special about the psychs that would necessitate the change there, but not elsewhere. So I'm just speculating, but I wouldn't be surprised if maybe the IRFs are next, maybe the long-term care. I just don't know. So we'll see what happens there. Now we're on to our final big topic, and that's the capital-related costs. Now there are a ton of different items we could cover with capital-related. We've obviously got about 25 minutes left, and I've picked out a few things that we want to focus on. But with that being said, I want to mention, and we'll see this at the very end slide or one of the last slides. This is on my list for YouTube videos as well. And it's probably going to be similar to what I've been doing with Oregon acquisition, where we're going to have a series of these. Oregon, I've got one out there. It's probably going to be a series of maybe 4, maybe 5. Capital, I think it'll probably be probably 4 or 5 as well. I don't want to make a really long YouTube video covering everything. I want to have them bite-sized, if you will. So capital-related costs make up a good chunk of a provider's costs on the cost report. And accuracy is important, of course. And every provider has capital. I mean, that's just the nature. You can't run a hospital without some sort of capital. Buildings, equipment, that makes no sense. Here are the regulations that cover the capital in general. 42 CFR 413.14, and then PRM 1, Section 122. And really the whole Chapter 1 covers capital. Again, I have a few topics I wanted to talk about. This one is the relifing of an asset. In other words, changing its estimated useful life. Generally speaking, the useful life of an asset should follow the AHA guide for depreciable lives of hospital assets. And if it needs to be changed, there need to be some factors that are in the section 104.117. Basically, you need to prove that the wear and tear has been more than you expected. It's technologically obsolete. You need to, it's only going to last another year or two instead of the 5 years it was intended. So you need to prove those types of things, that you're going to need to either shorten or lengthen the life of this asset. Now, the other thing I should have mentioned at the beginning, for facilities like a critical access hospital, capital is extremely important. For new hospitals, acute care hospitals that are brand new in a brand new building, then it's important for the first 2 years because you get cost reimbursement for that. For other facility types, again, it may have a small reimbursement impact, but it has a huge data impact for CMS. So it's important, regardless of what it does to your reimbursement on this current year. That's why we even bring these things up. But the change in useful life, if you can prove that you have one of those factors that are in this section and you need to change the life, then you can submit a request for that, but it's not going to be retroactive. It's going to be effective for that cost reporting period forward. The same thing applies to your GAAP reporting for your financial statements. If you change your useful life, it's a change in estimate. You don't go back to the prior years and recalculate depreciation for the new life. It doesn't do that. You don't do that. It's not a mistake. You change depreciation going forward. So whatever your remaining net book value of that asset is, it just gets spread out over the new remaining life, whatever's left. And your cost is going to be different than it otherwise would have been. So that's all we're talking about with the relifing. Comes up every now and then. Square footage is a big topic that covers a lot of things. This is a very simple percentage of all that capital cost. That's how that works. So getting that square footage right is important. It's a statistic on B-1, but when we audit it, if we need to audit it, we're looking for evidence that that square footage is proper. A floor plan, in some rare situations, especially for a new hospital, we might actually go on site to count some of the square footage that you reported. So the biggest question is, what rules apply to square footage? We're going to talk about a few of them here. The first one I have is dealing with idle space in the hospital. What is it being used for, or is it being used for anything at that point? Let's jump to the extreme here. If space has been taken out of service and there's no known usage for that in the near future, not even really storage for a particular area, it's just a shell, I don't want to say shell space. Yeah, shell space could be one of them, but it's out of service with no plan known at this point. For the current cost report, if that's out of service and it's other than temporary, that is going to be reclassed to a non-reimbursable cost center because it's not being used for patient care purposes. It's just sitting there. So the cost has to be carved out, and it's done through a reclass to a non-reimbursable cost center so that cost can step down and get carved out of the cost report. If it's temporary and you have a plan, but you had to pull it out of service for just a period of time, again, for a reasonable amount of time, it can still remain with the original cost center that it went with. But if that goes past a year, we're going to start really looking into it. That's the point. Now, if you can prove that space is being used for storage for an area, and you can tell, and even if it's used for, let's say, 2 or 3 areas, if you can dissect it and tell us how much of that storage square footage goes to each area, we can use that as well. That's perfectly fine. But the point is, we need to know the status of that space. And, if we were to go on site, we would be looking for evidence that, yeah, it's clearly used for storage, or it's clearly empty, not being used for anything. So that's idle space, a fairly obscure topic, but it does come up. Another topic that this was actually discussed, way back in the 60s when Medicare was first brought up, the some of the old training manuals from even the AHA, they discussed how to count square footage, even though, we're not PPS at that point, but it was obviously a cost reimbursement back then. So it really mattered then. There are 2 methods that are approved, gross versus net. And really the distinction between these two is essentially, what do you do with areas that are not clearly used by a particular department? They're definitely used by a lot of departments, but you can't really easily carve out square footage. It's not a well-defined room, for example. Common areas, that's the term we'll use there. Hallways, elevators, waiting rooms that are used by multiple departments. Cafeteria, that'd be different. That's for cafeteria, of course, but things like that are very common. The entryway, vestibules, things like that. So how do you count them? Where do you count them? Do you count them? Gross versus net is what determines that. If you're using the gross method, you're counting everything. Gross means without subtraction. So you're counting everything. And for example, if you have a hallway between 2 departments, the gross method says you start with the outside of the wall. That is where your square footage starts, and you go all the way to halfway through the hallway, and that counts for the department that's adjacent to that half of the hallway. The other half of the hallway would be counted as part of the other area. And you do the same basic thing with any area that's adjacent to a waiting room. It might not be halves, it might be triplet or a trisected, quartered, anything like that, but you'd split it that way. So that's the gross method. And that assumes you have a floor plan that we can get an outside of the wall square footage count. The net method, which is actually easier, basically says if it's truly a common area, you're not even going to count it. Your total is going to be reduced, and obviously each department, their amount is going to be reduced as well. And then whatever the percentage is, that's what you're going to use. It may help certain departments, it may hurt certain departments, but as an overall hospital, using the net method, you're still going to have, your cost is still going to be accounted for. It's just the allocation of it that's going to be skewed a bit. So the net method says don't count common areas at all. And now the definition there is, what is a common area? And furthermore, what does it relate to? There's a concept that we call function over location. And basically we're looking at what function that area serves, not just what area is that closest to, what department is that closest to. So if you can prove that it serves a certain function, it may be well away from that department. Again, storage is a good example, but if we know what it relates to, we're going to count the square footage with that functionally related area. That's what it points to. And Cheryl, so you have a good question there. Areas that use vacant space for storage that can be identified as used for a particular department does not have to be moved to a non-reimbursable line. So if that storage, if you can prove that if it has a patient care purpose, if you need the storage to run your hospital, it's not just random old storage of stuff that's never going to relate to patient care. So if it's necessary storage for something that's ultimately going to be used for patient care, then it can be allowed for that department. But again, if it's just very, very general storage, it's a different story. So it goes down to, can you show that it's related to patient care? And really in the cost report, that's what drives everything. Ultimately, everything has to relate to patient care to be allowed. So hopefully that helps to clarify what I said earlier more quickly. I kind of ran through that quickly earlier, but that's what it boils down to. So very good question there. And the next topic we have after square footage is losses on the disposal of assets. Now, again, this is something that is fairly obscure, but obviously disposals of assets happen. So we have a variety of things to look at. We need to look at the methodology of disposal. If it's a, and by the way, this word, I meant demolition here. I just accidentally typed in disposal. If it's a sale, donation, or even a scrapping, these are not allowed. The losses on sale, donation, or scrapping are not allowed. Sale is very, very clearly, it's been clearly for several decades included in the policy manual. But donation is in a separate section of the policy, and scrapping, it has its own little section as well. The thought is that a donation is essentially a $0 sale, and it's any loss from remaining depreciation is not going to be allowed for Medicare reimbursement. A scrapping will not be allowed by itself, but when we talk about scrapping of something, and when we talk about a bigger building and pieces are going to be scrapped and sold out, that can be used, that revenue can be used to offset the loss itself. So we'll see that piece in just a bit. But what I want to focus on here are the two that are allowable. The demolition, which again, this is supposed to be demolition, and abandonment theoretically could be allowable. Now, loss on demolition, we really have two different things there. We have the lost net book value. So that asset had some remaining depreciation that never got to be taken and reimbursed by Medicare. That's one piece of it. But also you have the loss related to just the cost you incurred in disposing that asset, in demolishing that asset. That cost can be lumped in there as well. But there are some pretty specific requirements for that I'll get into in a bit. Abandonment, which I think I have some more detail in the next slide. This is actually a very rare one because it's a pretty stringent bar to hit. Abandonment is not a general term. There's a very specific definition for it, not in the manual, so to speak, but just in general, legally, I guess you could say, abandoning an asset. Abandonment means you completely give up control over it. You do not make any decisions further about that asset, and it was not donated because obviously if you donated it, you didn't abandon it. You made that final decision where it would go. Abandoning an asset essentially results in it escheating to the state, and that's the ESCHEAT. It's a legal term. If you abandon it, the state now takes over ownership of it, and they can do whatever they want with it, sell it, give it away, use it for some other purpose. So technically speaking, the only way to have a loss on abandonment is if you can prove that the state took control, it is escheated to the state. If you exercise any final control in determining where that goes, it is no longer an abandonment. It's basically a donation to some party, the church or whoever, which will not be allowed. So let's get on to the next. I guess I don't have any more. Well, let's just talk about these a bit. I think I was kind of rushing toward this last slide, but when I do have a video on these, I'll have more detail. The slides will be a little bit more broken out. So the point here is if you demolished or abandoned that item, the question is, where's that cost going to be allowed? Or I should say, what period, when is it going to be allowed? If it's going to be allowed, and in what amount, of course. So you have to take a look at a few different things. The first thing is the materiality. What are we talking about? If it's less than $5,000, we're not concerned. We're just going to report it in that period in which the loss was incurred. There's no use doing more tests and spreading it out. It still has to be allowable. It can't be a sale or donation, but the amount's just going to be allowed there. We're done with it. If it is more than 5,000, so it's material, we need to look at it further. And if it is more than 80% depreciated, then we're basically saying it's material, but it's still a fairly small amount. Most of the asset's been handled properly. We're down to the last little bit of its life. So we're going to report it in the period of disposal, but we have to use the reimbursement impact from all prior years. In other words, we're not just going to allow that cost this year and then whatever its corresponding reimbursement impact is this year. We need to look at what it would have done to reimbursement if that cost was allowed in the earlier part of its life, technically all the way back to the beginning of this asset's life. So that's a very in-depth calculation. You have to figure out how much of this depreciation, if we knew what the life would have been, the shortened life, go back to those earlier years and basically recalculate the Medicare reimbursement from each of those years. And then roll all those reimbursement impacts up and allow that reimbursement in this current year. So it's a very in-depth calculation. And that's something that, we would do as a MAC. At that point, we'd verify it. Let's say it's more than 5,000, but less than 80% depreciated. The thought is basically, why are you disposing this asset that's still relatively new? And depending on the asset type, it needs to either be approved. The disposal needs to be approved by the state or MAC, I should say. And if it's approved, then hey, it's going to be allowed, and we'll use that same methodology we just talked about, the prior year's impact. If it's not approved, then the only way we're going to allow any loss is if you replace that same asset. So for example, a building, if you replaced a new hospital and it's the same basic hospital, just a new building very nearby, then that loss would be allowable. That's if it was not approved. Oh, and I back up there. I said earlier we would use that same methodology. That's actually not the case. The methodology in this situation is it gets amortized over the remaining life of the asset, what the remaining life would have been for that. So different way of treating that. That's all detailed in section 122, and I think even some additional sections. So that takes us through our last big topic. And again, there was one other piece I wanted to mention here. One example. Land. Let's say you have a building on land. You're ultimately wanting to sell that land. If that building, maybe an old hospital building or a medical office building, is razed, cleared, demolished, so to speak, the costs related to that and the lost building depreciation, they become part of the raising costs. I'm going to focus on that. The raising costs become part of the basis of the land, the cost basis of the land. And then when you sell it, you might have a loss, you might have a gain. It's land, so you may very well have a gain. But the point is that raising cost will not be part of the cost we allow for loss on demolition. The reason for that is that the reason you demolished it was so you could sell the land. So it becomes part of the land's basis. So that's one of the things that has come up a few different times. And again, if the building itself, if we're talking about the lost depreciation, we need to run through those other requirements. Why did you get rid of it? Was it approved? Did you replace it? Things like that. So that takes us to the wrap-up portion of this webinar. And again, this is the same basic thing that I've had in every other webinar. I keep adding a little bit to it. Here are our two links. We have the WPS website. We have our YouTube audit playlist. And the next few slides are just a list of all the YouTubes we've had. I'm not going to go through them. Shows you the date, the length, the link, the topic. So we have quite a few of them. And this is all found on our website, by the way. We have a list there as well. The one thing I will focus on is the last slide, some of the newer stuff. We had our June webinar that's out here. We have a webinar on those SSI realignments. We talked about a lot of that stuff. the August webinar. Organ acquisition was a new webinar since that last one. And RHC consolidations and base rates, we have a new webinar out there as well. Or not a webinar, a YouTube video, I'm sorry. So we have a YouTube video. I said earlier that organ acquisition, this is cost report flow. That's what this one is. We're going to be having a series of about 4 or 5 of these covering different aspects of organ acquisition. And the 3 that I have on the list for the future, I talked about capital. I talked about all-inclusive rate providers. Capital is going to be a series as well. But then self-insurance. This is another fairly obscure topic that has come up. We've had questions over the years, so I'm going to roll this up into a webinar or a YouTube video and put that out there as well. Hopefully by the next webinar we have, these will be in our completed list, and I'll have some new to-do stuff there. Just a list of our webinars up through today, December 2024. And that takes us to the end. So I just wanted to, first of all, if you have any questions now, feel free to start typing them in, and I'll address those in a few minutes. But the other thing is just another reminder on the survey. If you have a chance, it just takes a few minutes to complete that survey. If you're not from a Mac, of course, if you can complete that survey and provide any feedback you have, any new topics you'd like to see, whether it be through a webinar, whether it be through a YouTube video, we get those comments. They are anonymous, by the way, unless you put your name and contact information in the comment section. So they're anonymous, but feel free to put any comments you have. We use that to try to improve our offerings and try to target the things that are really asked. You know, that self-insurance, we've had some comments on that, and that's what has led to us bringing that in now as well. So with that, we are just a few minutes short, or a few minutes early. So I'm going to just wait here and see if there are any questions. But otherwise, if you're done, if you don't have any questions, thank you for your time today. And I wish all of you a great holiday season coming up. And I look forward to talking to you in our next webinar. So have a good one. I'll stay online for a few minutes for any questions.